Hi, this is Dr. Poole, and this presentation is going to cover polyps of the colon and related polyposis syndromes that predispose to the development of adenocarcinoma. Polyps occur throughout the gastrointestinal tract, although they're most common in the colon. A polyp of the colon refers to a protuberance into the lumen above the surrounding colonic mucosa. Polyps may be macroscopically described as sessile, meaning the polyp is attached to the mucosa by a broad, flat base, or pedunculated, which means the polyp is attached to the mucosa by a stalk, which contains smooth muscle and submucosal tissue. Polyps may be non-neoplastic, that is benign, or neoplastic, which means there's various grades of dysplasia which can progress to invasive carcinoma. Non-neoplastic polyps include inflammatory, reactive or hyperplastic, and hamartomatous polyps, while neoplastic polyps include adenoma, which are benign, and adenocarcinoma, which of course is malignant. Hyperplastic polyps are the most common non-neoplastic polyps in the colon. Hyperplastic polyps have an endoscopic and gross appearance of small nodules or polypoid lesions. They are typically located in the rectosigmoid colon and are less than 5 millimeters in size. Hyperplastic polyps have a characteristic serrated or sawtooth pattern and are composed of mature goblet and absorptive cells, the same cells that line normal colonic epithelium. Serration is typically restricted to the upper third of the crypt. The pathogenesis of hyperplastic polyps is incompletely understood, but they're thought to result from decreased epithelial cell turnover and delayed shedding of surface epithelial cells, leading to a piling up of goblet cells and absorptive cells producing the polyp. It's now appreciated that these lesions are without malignant potential. Their chief significance is that they must be distinguished from sessile serrated adenomas that are histologically similar but have malignant potential. Okay, these images demonstrate the typical morphologic hallmarks of hyperplastic polyps. Note that the serrated appearance, this wavy edge, is limited in this photomicrograph to the upper third or so of the thickness of the polyp. This is a little bit higher power view in panel B, again showing this wavy or serrated edge, and this is how these serrated knives get their name. You can compare it with panel C with the normal colonic crypts, which have a smooth lining, but you'll note that the cells are exactly the same. Inflammatory polyps of the colon should sound somewhat familiar, as we talked about these in association with ulcerative colitis in the food to fuel course. An inflammatory polyp may ultimately form as a result of chronic cycles of injury and healing, such as we see with ulcerative colitis, but it's not necessarily specific for that. Any form of colitis which is cyclical, such as intermittent chronic ischemic colitis, could produce the same type of polyp. The distinctive histologic features of a typical inflammatory polyp include mixed inflammatory infiltrates, that is, consisting of acute and chronic inflammatory cells, erosion of the superficial epithelium, and epithelial hyperplasia together with lamina propria fibromuscular hyperplasia, producing a granulation tissue like stroma. So this image highlights these features. You see loss of the surface epithelium, what we call erosion. Notice that the stroma of the polyp, that is the tissue in between the glands, has this granulation tissue-like appearance with vascular proliferation, You can appreciate on higher power the mixed inflammatory infiltrate and the fibromuscular hyperplasia, as you see these fibromuscular bundles extending up between the elongated, that is hyperplastic, colonic crypts. The third major type of non-neoplastic or benign polyps is the hamartomatous polyp. Now these are tumor-like growths that are composed of mature tissue native to the colon. These occur sporadically, that's the majority of them, or may occur as a component of various gastrointestinal polyposis, genetic or acquired syndromes, which I'll touch on next. Most of these are associated with little risk of malignant transformation, especially the sporadic ones. Hamartomatous polyps can be further divided into juvenile polyps, the majority of which are sporadic but can be associated with juvenile polyposis syndrome, and Peutz-Jeghers polyps, which are a type of hamartomatous polyp specifically associated with Peutz-Jeghers syndrome. Sporadic juvenile polyps are the most common type of polyp diagnosed in children and are estimated to be present in as many as 2% of asymptomatic children. The criteria for a diagnosis of syndromic juvenile polyps include greater than 5 juvenile polyps in the colon at one time, the presence of extracolonic juvenile polyps, and any number of juvenile polyps in a patient with a family history of juvenile polyposis. Sporadic juvenile polyps often occur or are first diagnosed in patients ranging from 1 to 10 years of age, with a peak incidence between 2 and 4 years of age. In contrast, patients with juvenile polyposis syndrome tend to present at an older age, with a mean age of 9.5 years. Their endoscopic and gross appearance ranges from relatively smooth, homogeneous pale sessile polyps to large pedunculated polyps with a coarsely nodular surface, like you see in this polyp from a colectomy specimen. The classic juvenile polyp is a well-circumscribed mass that frequently displays an eroded surface and numerous cystically dilated glands, like you can see in the middle of this polyp, which is seen on whole mount cut section. Juvenile polyposis syndrome denotes multiple juvenile or inflammatory polyps distributed throughout the colon or gastrointestinal tract. JPS is the third most common form of intestinal polyposis. Children with JPS usually present with painless rectal bleeding. Less than 10% have symptoms such as abdominal pain, rectal prolapse, or anal pruritus, constipation, or diarrhea. Extensive and extracolonic polyposis in the small bowel or stomach may cause GI and systemic dysfunction such as intussusception, protein-losing enteropathy, malabsorption, diarrhea, or significant hemorrhage. Two clinical forms of juvenile polyposis syndrome are recognized: an autosomal dominantly inherited familial form with no associated congenital abnormalities, and a non-familial form in which 20% of affected individuals show abnormalities such as congenital heart disease, hydrocephalus, or intestinal malrotation, among others. There's a high risk for the development of GI cancers which may or may not be associated with the juvenile polyps, so current management involves screening, including regular endoscopy and colonoscopic surveillance. The other major polyposis syndrome involving hamartomatous polyps is Peutz-Jeghers syndrome. This is an inherited syndrome that consists of two major and characteristic components: gastrointestinal hamartomatous polyps and pigmented macules of mucous membranes and skin. It's the second most common form of intestinal polyposis with an incidence approximately 1/10 that of familial adenomatous polyposis, or FAP, which I'll talk about later. It's similar to FAP in that it's inherited in an autosomal dominant pattern, but unlike FAP, the inherited dominant allele shows variable and incomplete penetrance. Germline heterozygous loss of function mutations in the gene STK11 are present in approximately half of individuals with familial Peutz-Jeghers syndrome, as well as a subset of patients with sporadic PJS. STK11, if you remember, is a tumor suppressor gene that encodes a kinase that regulates cell polarization and acts as a brake on growth and anabolic metabolism. As is common with other tumor suppressor genes, the function of the second normal copy of STK11 is often lost through somatic mutation in cancers that occur in Peutz-Jeghers syndrome, providing an explanation for this high risk of neoplasia seen in affected patients. The diagnosis of PJS can be made in infancy because most patients develop mucocutaneous pigmentation within 2 years of birth, and small bowel hamartomatous polyps are frequently symptomatic. More than 95% of patients with PJS demonstrate pigmentation of the mucous membranes at birth, specifically around the nose, lips, buccal mucosa, hands and feet, genitalia, and perianal region. Hamartomatous polyps present throughout the intestinal tract but are most common in the jejunum. Polyps usually number in the tens. Benign complications of PJS predominate in the pediatric population. Jejunal and ileal hamartomatous polyps often produce intussusception, leading to a partial or total bowel obstruction. When they're located in the rectum, hamartomatous polyps may prolapse, resulting in torsion, infarction, and GI bleeding. In adults with PJS, morbidity and mortality are related to the development of cancer. Tumors can develop in multiple organ sites in addition to the GI tract, including breast, lung, pancreas, uterus, ovary, cervix, and Sertoli cells of the testis. Importantly, and this is a high-yield bit of information, colon cancers can develop at sites without Peutz-Jeghers polyps. The follow-up of these patients is, of course, screening and regular surveillance of high-risk organs, including the GI tract, breast, pancreas, and reproductive organs. These are two images demonstrating the mucocutaneous pigmentation that's characteristically seen in Peutz-Jeghers syndrome. Notice these macules on the dorsal surface of the tongue, and all these pigmented macules around the mucosal portion of the lips. The right shows intussusception from the external view. This is a portion of small bowel that's folded into this segment, which is rolled upon itself. The dotted arrow shows is supposed to represent anyway this segment of bowel that's going into this other segment. The polyp that's located in this segment, which you can't really see, acts as an anchor to pull the segment of bowel that you can see into that lower segment. That's called intussusception. Peutz-Jeghers polyps may be sessile or pedunculated and often show a smooth lobulated surface. Their histologic appearance is quite distinctive and characterized by hyperplastic mature epithelium that's appropriate to the anatomic site, which is divided by broad bands of mature smooth muscle. The smooth muscle fibers commonly fan out from the center of the polyp to produce an overall tree-like appearance. This is a whole mount of a Peutz-Jeghers polyp to demonstrate the tree-like arborizing appearance which you see with Peutz-Jeghers polyps. The first two panels from left to right, panels A and B, are from a small bowel Putzjäger's polyp, and the lining epithelium shows reactive and hyperplastic features, which you can appreciate by some of these more oddly, almost stellate shapes, branching, but the cells lining these glands are still native to the small bowel and include goblet cells, these pink absorptive type cells. There's neuroendocrine cells, which you can't really appreciate on routine H&E sections, but you can appreciate these Paneth cells that are at the basis of the crypts. The farthest panel to the right, panel C, shows a colonic type of Putzjäger's polyp, which again are composed of goblet cells with few interspersed absorptive cells, again, which are native to the colon itself. Okay, we're in the home stretch. Now we'll talk about neoplastic polyps, which we call adenomas. So colonic adenomas are benign epithelial neoplasms, which can be a precursor to adenocarcinoma. These show cellular and architectural changes of dysplasia, which is a precursor to carcinoma. These are extremely common. Nearly 50% of the U.S. population over the age of 50 have one or more colonic polyps. The management of adenomas includes screening colonoscopy and polyp removal to prevent the development of colorectal carcinoma. Adenomatous polyps may have a smooth, lobulated surface, like you see in the left panel, a velvety or finely nodular surface, which is demonstrated in the image in the middle panel, or they may be pedunculated, like you see in the panel on the right. Adenomas can be classified as tubular, tubulovillous, or villous based on their architecture. These categories, however, have little clinical significance in isolation, and the risk of invasive adenocarcinoma is more related to polyp size. Tubular adenomas tend to be small pedunculated polyps composed of round or elongated tubular type glands. In contrast, villous adenomas, which are often larger and sessile, are covered by slender, elongated, villus-like structures. Tubulovillous adenomas, as the name suggests, have a mixture of tubular and villous elements. You can compare dysplastic epithelial cells in this panel, which are located here at the top, with non-neoplastic normal colonic epithelium at the bottom here. Note that the dysplastic epithelial cells have an increased nuclear to cytoplasmic ratio, are hyperchromatic with elongated nuclei, and show nuclear pseudostratification. Sessile serrated adenoma is lined by goblet cells without cytologic features of dysplasia, and as the name indicates, have this serrated or sawtooth appearance to the gland seen in profile. Now this lesion looks awfully similar to a hyperplastic polyp, but can be distinguished from a hyperplastic polyp by extension of this serrated appearance to the crypt bases, which results in this lateral growth, which you don't see in hyperplastic polyps. Remember, in hyperplastic polyps, these serrated glands are limited to the upper third of the epithelium, and hyperplastic polyps are non-neoplastic. I'll have a little bit more on serrated polyps next. Serrated polyps are a special type of adenomatous polyps, but they're a heterogeneous group with variable malignant potential. These include hyperplastic polyps, which we've already talked about and are non-neoplastic or benign, traditional serrated adenomas, which are more polypoid or even pedunculated but lined by serrated adenomatous glands, and sessile serrated adenomas. We'll spend a little more time on these sessile serrated adenomas because these frequently exhibit dysplasia. SSAs, particularly those with foci of dysplasia, are considered the likely precursor lesions to sporadic microsatellite instability high colon cancer, which I'll talk about in the next presentation. Risk factors for a synchronous advanced adenoma in patients with sessile serrated polyps include a sessile serrated polyp or adenoma greater than 10 millimeters, location in the proximal colon, and the presence of dysplasia. These polyps are managed like conventional adenomas with complete excision recommended. Familial adenomatous polyposis syndrome is an autosomal dominantly inherited syndrome characterized by hundreds to thousands of adenomatous polyps throughout the colorectum, as well as a variety of extracolonic manifestations. It's the most common polyposis syndrome, occurring in approximately 1 in 10,000. Again, it has an autosomal dominant inheritance pattern with mutations in the APC gene and shows a high penetrance in affected families. 30% of patients with FAP, however, have spontaneous mutations of the APC gene. The adenomas and carcinomas that arise in FAP are indistinguishable from sporadic adenomas that we just talked about. The average age of colorectal cancer at diagnosis is 39 years, and more than 90% of patients develop colorectal cancer by age 50 years. 100% of patients have upper GI polyps as well, which are typically fundus gland polyps of the stomach or conventional adenomas in the small intestine. Again, like sporadic adenomas, the incidence of malignancy is directly related to adenoma size as well as the frequency. Most patients are asymptomatic until puberty. Adenomas often present years before symptoms actually occur, so they're present in early childhood. The most common symptoms are rectal bleeding or diarrhea. After the development of symptoms, carcinomas develop on an average of 6 years. Synchronous cancers are present in 40% of patients, and metachronous cancers are also common. So these features of FAP are directly related to prognosis and therapy. There's a 100% risk of colon cancer developing without any intervention. Because of synchronous and metachronous cancers, the only treatment is prophylactic total colectomy. However, following colectomy, because of the presence of gastrointestinal polyps throughout the GI tract, the most common cause of mortality is the development of periampullary cancer, which occurs in about 22% of patients. Again, the adenomas and carcinomas that arise in FAP are not morphologically distinct. They're indistinguishable from their sporadic counterparts. And also similar to sporadic adenomas and colorectal carcinomas, the incidence of malignancy is directly related to adenoma size and frequency. It's the sheer number of polyps that dramatically increase the risk of carcinomas developing in these patients. In the panel on the left, you can see that the colonic mucosa is carpeted by innumerable dome-shaped adenomas with an infiltrating carcinoma present, indicated by the arrow here. The middle panel shows another case of FAP in which the adenomas show wide variation in their size, from these larger polyps to tiny polyps like this, with intervening normal colonic mucosa in between. The panel to the right shows an example of polyps from a patient with attenuated FAP, in which there's variable penetrance of the APC gene mutation. In this patient, as mentioned, only about 30 adenomas were present, and they were all located in the cecum and proximal right colon. They still have the same risk of developing carcinoma, and you can see the wide variation in size in this case as well. There's one final polyposis syndrome that I need to tell you about, and that's the MUTYH-associated polyposis syndrome, which is distinct from FAP because it's autosomal recessive inheritance, and this syndrome is caused by a biallelic germline mutation in the MUTYH gene. MUTYH is a base excision repair gene whose protein repairs oxidative damage to the DNA. Failure of this base excision repair process results in mispairing of guanine with adenine and results in somatic CG to AT transversions in multiple genes, including, guess what, the APC and KRAS genes. The target genes are then mutated as a consequence of oxidative damage, and this strongly influences the polyposis phenotype. The phenotype is similar to that of attenuated FAP, in that the polyps develop at later ages, there's fewer than 100 adenomas, and there's a later appearance of colon cancer at ages 50 or older. Although adenomas are the predominant polyp type in patients with MUTYH-associated polyposis, you can also have multiple serrated polyps and or sessile serrated polyps. So if you have a patient with multiple serrated polyps, it might be worth investigating for this mutation. Alright, that's it on polyps and polyposis syndromes of the colon. Be sure to tune in for the next presentation on adenocarcinoma of the colon. Thanks.